Hello everyone. In this session, we are going to discuss about chickenpox. Chickenpox, also known as varicella. It is a continuation to our chapter Epidemiology of Communicable Diseases. In this session, we'll discuss chickenpox, following sections the other topics. What are the objectives to this session? In this session, we will be covering about the introduction, the epidemiological determinants to chickenpox. We will also know what is the mode of transmission, how the chickenpox gets transmitted from one person to other person. The clinical features. Clinical features are nothing but what the patient comes up with, the signs and the symptoms. Diagnosis, how the doctor is going to conclude that it is chickenpox. The prognosis and complications. Prognosis is how the disease is going to take its path. And complications. We will also know about its prevention, how we can prevent the chickenpox from occurring. Let us begin with the introduction to chickenpox. Chickenpox, as I told you earlier, chickenpox is also known as varicella. Chickenpox, also known as varicella, is an acute, highly infectious disease which is caused by varicella zoster virus. So you can see the picture here, the varicella zoster virus. We have the Google images. Let's say thanks to the Google photos, and we have a beautiful varicella zoster virus picture here. So you can just snap it in your memories. We have varicella zoster virus which is causing chickenpox to the people. It is characterized by a vesicular rash. Okay, the chickenpox is having a vesicular rash. And now let us see, it is worldwide in distribution and it occurs both in epidemic and endemic forms. So we see chickenpox is a worldwide. Okay, all over the world chickenpox occurs. And in both epidemic forms and endemic forms. Endemic in a regular frequency. A set of people every year will be suffering with chickenpox. That is known as an endemic. Epidemic, once the endemic flares up, a large people in the community are getting affected by chickenpox at one certain time and the frequency is spiking up. Then we consider it to be an epidemic. So chickenpox is found in the form of an endemic, also in the form of an epidemic. People who get the virus often will develop a rash of spot that looks like blister all over their bodies. I said you there will be a vesicular rash. You can see here the vesicular rash that looks like blisters all over the body. You have a picture here. The vesicular rashes which look like blisters all over the body. The reddish rashes you can see. The blisters are small. They sit on an area of red skin. They can be anywhere and they are of a varying size. Moving further to the problem statement. Also, we need to know that the chickenpox and herpes zoster, they are now regarded as different host responses. There is a clear differentiation between herpes zoster and chickenpox. They have different host responses to the same etiological agent. We know the herpes zoster is also caused by varicella zoster virus. Chickenpox is also caused by varicella zoster virus, but both have same etiological agent but different host responses. How the person responds, the reactions in the body, the signs and symptoms, the clinical features in both is going to vary. The inoculation of the zoster vesicle fluid in the children will produce chickenpox, and the children who have recovered from zoster virus related infection, they become resistant to varicella. So once a person is affected with zoster virus related infection, if it is chickenpox or the herpes zoster, then he will become resistant to that varicella. If he has herpes zoster, then he becomes resistant to chickenpox. It gives immunity because it is the same etiological agent. Once a person gets affected, the body becomes resistant. The next time it provides immunity. Okay. That's something like a little extra information from our park text. And now we'll move further to the problem statements. So, based upon the conservative estimate, the global annual chickenpox disease burden is 4.2 million severe complications and 4,200 deaths. So, we see it's quite a large burden on the countries. So, it's a global annual chickenpox disease burden is 4.2 million people are suffering with chickenpox. That is the estimate what we have. Based upon the conservative estimates, we see that it also leads to severe complications, which is leading the people to get hospitalized. And unfortunately, the disease gets so severe with severe complications that 4,200 people ended up in being fatal. In the pre-vaccination era, in the high-income developed countries, we see it was about 3 per lakh cases compared to 1 to 3 per thousand cases for measles. So when they compared the measles cases to chickenpox cases, it was 1 to 3 per thousand cases for measles, but here it was 3 per lakh cases for chickenpox. In India, 2013 to 2028, in 2013, 28,090 cases with 61 deaths were reported. The case fatality rate for chickenpox is 0.21%. Highest cases were reported in the state of Kerala, and the highest deaths were recorded in West Bengal. So we see the highest cases were in Kerala, and the highest death, the highest mortality was observed in West Bengal. This could be important. Problem statement could be important for your AIGPET exams, entrance exams, but from your university point of view, for your examinations, you need to more focus upon the epidemiological determinants, the clinical features, the complications, preventions, and that part, and the problem statement is not that important. Moving further to the epidemiological determinants, the agent factor, host factor, the source of infection, infectivity, environmental factors, and incubation period. So let us begin with the agent factor. So far you are able to tell me what is the agent which is causing the chickenpox. I want it down in the comment section. If you guys remember which is the agent which is causing the chickenpox, you can quickly jot it down in the comment section. So now we see the agent factor is Varicella zoster virus. The ones who said is right. And it's a DNA virus. So we see it is a DNA virus. The primary infection causes the chickenpox. The recovery is followed by a latent infection. So what is the latent infection? The infective organism is present in the body, but it is not in an active form. It is in a dormant form. It is in a silent stage. It is not manifesting the signs and symptoms in the patient, but it is in a latent infection. Host factor, age, it occurs primarily among the children. We see everybody suffers from chickenpox when in their childhood. So it's primarily affecting the children under 10 years of age. The disease can be severe even in the normal adults. Immunity, I said you, one attack is going to give you a considerable durable immunity, and the second attacks will rarely occur. During pregnancy, if the infection occurs, if the chickenpox occurs, if it affects a pregnant woman, then a risk for the fetus occurs, leading to congenital varicella syndrome. So what happens when this varicella zoster virus is affecting a pregnant mother? If the pregnant mother is affected with varicella zoster virus, the baby will have congenital. Congenital is inborn, from birth, those diseases will be there, and it will lead to congenital varicella syndrome. Moving further, what is the source of infection to this chickenpox? The virus will occur in oropharyngeal secretions and the lesions of skin and mucosa, and rarely from the patient with herpes zoster. I said you the varicella zoster virus is going to cause both herpes zoster virus infection, herpes zoster, and it is going to cause chickenpox. So the person with chickenpox rarely gets affected from herpes. He usually gets the infection either from the nasopharyngeal secretions from the other person, okay, the nasopharyngeal secretions from the other person. And we will see further in the next slide. I've given you beautifully. You can see here, person to person transmission is through respiratory droplets or in contact with an infected rash. You can see the droplet aerosol. The picture is not too clear, but you can have an idea about it, okay, how the aerosol particles, they get disseminated in the atmosphere, and the other person inhales and he gets the infection. So it's either because of the oropharyngeal secretions. Also, the lesions of the skin and the mucosa can also lead to the spreading of the chickenpox, and rarely from the patient with a herpes zoster. So we discussed this point. Moving further to the infectivity, the period of communicability of patients with varicella is estimated a range from 1 to 2 days before the appearance of rash and 4 to 5 days thereafter. So what did we discuss now? The infectivity period. So we see here this person was infected. From the nasopharyngeal secretions, the other person got the infection. So how long does it take for the infection to get established in the second person? It takes 1 to 2 days before the appearance of rash. Before the rashes appear on the body, before the appearance of the rashes, 1 to 2 days before the appearance of rash, and also 4 to 5 days after the appearance of rash, this person remains infective. So infectivity period, how long does this person be infective, actively infectivity he can spread to the other person? It is 1 to 2 days prior to 4 to 5 days after. Guys, just don't confuse with this. This is infectivity and this is the incubation period. Sorry, the incubation period is the thing which will take from the spread of the infection to the appearance of signs and symptoms. To the spread of the infection to the appearance of signs and symptoms is the incubation period, which is 14 to 16 days. Okay, from the spread to the establishment of signs and symptoms is 14 to 16 days. And how long does this person remain actively infected, he have the capacity to infect others, is 1 to 2 days prior to the appearance of rash and 4 to 5 days thereafter he remains infective. Moving further to the environmental factors, it shows a seasonal trend occurring mostly during the first 6 months of the year. In tropical regions, during the first 6 months, Jan to June, it remains a seasonal trend. Later, during the winter and early spring, it seems to appear in the temperate regions. So, in the tropical regions, it is seen to occur during the first 6 months. In winter and spring, in the temperate regions. Varicella zoster virus is heat labile. Outside host cell, the virus survives in external environment for only a few hours. So heat labile, it cannot withstand the heat. So once it goes outside the host, the virus, once it gets disseminated into the environment, into the external environment, it stays alive only for a few hours. Later, it dies. Moving further to the incubation period, I explained you this earlier with the infectivity. Please don't confuse. Infectivity is how long the person remains infected, how long he can spread the infection to the other person, and incubation period is the entry of the virus into the other person and the establishment of the infection. Let's move further to the modes of transmission. How does the chickenpox spread? So, from the intro part, we know 2 points. One, it will spread from person to person by droplet infection, and most patients are infected by face to face contact, and also through coughing, sneezing, and the portal of entry of virus is through upper respiratory tract or through the conjunctiva. So you can see the picture here beautifully. You can memorize the mode of transmission from this picture. It's spread from person to person via the respiratory secretions to face contact, aerosols, and then coughing, sneezing. And how does it enter the other person is through the nasopharyngeal, upper respiratory tract, and the conjunctiva. The virus can cross the placental barrier and infect the fetus. Like we discussed earlier, if the chickenpox is affecting a pregnant mother, then the baby suffers from congenital infections. So the chickenpox virus will travel across the placental barrier of the mother, and from the placental barrier it will reach the fetus. So let's just draw here. Okay, this is the uterus, and this is our placenta. Okay, this is our placenta, and this is a baby. So what happens is the zoster virus, varicella zoster virus, what does it do? Varicella zoster virus, it travels across the placenta. Traveling across the placenta, it will affect the fetus, and the fetus will suffer from congenital abnormalities and also congenital varicella syndrome. Clear? Let's move further to the clinical features. So now we come to the signs and symptoms. So if a patient comes to you, so how are you going to say that this particular patient is suffering from chickenpox? So we need to focus on this part as a physician, as a medical student. You need to focus on how you're going to recognize the clinical signs and symptoms in the patient. The clinical spectrum may vary from a mild illness with only few scattered lesions. So we see it can either be a mild illness where there are only few lesions which are scattered, which are just here and there. You can see few lesions in a patient, or it can be severe febrile illness. So what do you mean by febrile now? Febrile, if a person is having an infection, also suffering with fever. Severe febrile illness with the rashes, he is having the widespread rashes. He is having fever, severe fever, high fever, and widespread rashes. Clinical features will be divided into 2 stages. We have pre-eruptive stage and an eruptive stage. In the pre-eruptive, before the eruptions, before the spots on the body, the rashes, before they erupt on the body, what is the patient going to present with? Onset is going to be sudden onset with a mild to moderate fever, back pain, shivering, malaise. Memorize it again. If a person is having chickenpox, he is going to, if he is in a milder state, he will come up with fever, back pain, general malaise, and shivering. Very brief stage lasting for 24 hours. In adults, it can be more severe, and this pre-eruptive stage can also last for 2 to 3 days before the rashes come. In the pre-eruptive, the eruptions have not yet come. He's only going to come up with fever, back pain, malaise, shivering, and it will last for 24 hours. In adults, 2 to 3 days. Now let us move further to the eruptive stage. The most important thing is the distribution of the rashes. So once we exactly remember how the rashes are getting distributed, even if you are quite confused about the appearance of the lesions, the distribution is going to give you a clue to diagnose whether it is chickenpox, it is smallpox, it is herpes zoster. We know the rash will have its own characteristic appearance. Also, the distribution will help us in additionally to diagnose the case. So let us see the distribution. The rash is going to be symmetrical, okay, on both right and left side. Both sides it is going to be symmetrical. First it will appear on the trunk, then it will come to the face, arms and legs. Okay, again let us see how is it going. First it appears on the trunk. Okay, first it appears on the trunk. You can see like this. One is on the trunk. You can remember like this. One on the trunk, then it comes to the face. Okay, then it is going to the okay, I don't know, there's some error. Just a second. Yeah, let's continue. I'm sorry. Okay, we'll keep it like this. Let's just draw this here. Okay. So first it is going to appear on the trunk. You can write it as 1. First comes on the trunk, then it goes on the face. Okay, 2 eyes. We have 2 eyes, right? So 2 eyes. Then it goes. You can remember it as a nose. 2. The first one is on the trunk. The second one is on the nose. You can remember 2 is on the face. And then comes arm. Okay, arms. We have 3. It goes on the arms, and next it goes on the legs. Clear? Trunk, face, arms and legs. Mucosal surfaces also may be involved. So the inner surfaces, the mucosal surfaces, the palate, the covering, the mucosal surfaces in your mouth can also be involved. Rapid evolution. The rash advances quickly through the stages of macule, papiole, vesicle and scab. Now I have what is the macule, papiole, vesicle and scab. I will first explain you how to differentiate these, and then let's move on again to the rapid evolution. So you really need to know this very clearly to study all of the further topics. I request you to just note down these 4 upcoming slides. They're very important. That is how you're going to differentiate between a macule, a papiole, a vesicle, a blister. Whenever such terms come up, I will try to explain in detail so that it helps you to differentiate. So macule. Macule is flat. It is circumscribed alteration in the color of the skin or the mucous membrane. You can see it can either occur on the skin or in the mucous membrane. It is circumscribed. You can clearly draw the margins. Okay, it is circumscribed. Can you see a bump here? No, it is flat. It is flat. It is clearly circumscribed. There is alteration in the color of the skin and the mucous membrane. You can clearly see the alterations in the color. Very important is the size. The macule, it is going to be flat. It is going to be less than 0.5 centimeter. What are you going to remember about a macule? It is flat. There is a change in the color. Third thing, it is less than 0.5 centimeter in size. Let's move further. What is a papiole? A papiole is a solid elevated lesion less than 0.5 centimeter. You can see here it is again less than 0.5 centimeter, but it is elevated. You can see the elevation, clear elevations here. And papulosquamous lesions, the papules are surmounted with scale. Whenever there is papulosquamous lesions, they will be surmounted with a scale. Sessile pedunculated, dome-shaped, flat-topped, rough, smooth or umbilicated. So what are the various types of papules? We can have pedunculated papule, dome-shaped papule, flat-topped papule, rough, smooth or umbilicated. I don't want you to go into depths. Just remember, I don't know why the sessions are getting started. I'm sorry. Yeah, just remember the macule. I guess this is more than 0.5 centimeter. Okay, sorry guys, this is more than 0.5 centimeter. Macule is more than 0.5 centimeter. Only thing is it is flat, there is change in the color. Papiole, it is elevated, it is less than 0.5 centimeter, it is solid lesion. We move on to the vesicle. It will be smaller than 0.5, or it is going to be equal to 0.5 centimeter. What is the speciality about a vesicle? A vesicle is going to be fluid filled. It is going to be fluid filled. Primarily, it can be filled with a clear fluid. Later on, it can become fistular. The pus can get accumulated, the vesicle can get umbilicated, or an erosion can occur. You can see here the erosion of a papiole, or it can be umbilicated. When too much of fluid gets accumulated, it can get umbilicated. Moving further to the pistule, a circumscribed raised cavity in the epidermis or infundibulum containing pus. You can see again here it is circumscribed lesion. It is a circumscribed. What do you mean by circumscribed? I just told you earlier. Clearly you can define it here. It is starting and ending here. Okay, it is a circumscribed and a raised cavity. You can clearly see it is raised. It is raised from the skin. It is containing pus. The collection of leukocytes, the cellular debris, or there can or not be bacteria in it. It will vary in the size. In certain situations, it can also coalesce, and once it coalesces, it will form the lakes of pus. Generally, it will heal without scarring. Usually, these papules will heal without scarring. So, this is the intro part to the skin lesions. It will be also useful for your medicine dermatology sessions. You can just have screenshots of this in your phones, or note it down however you feel comfortable. So we were discussing how the eruptive stage occurs. The rash advances quickly through a stage of macule. You see, first the discoloration comes. Then it turns into a papule, slightly raised, and then it turns into a vesicle. The fluid gets filled. Later forms a fistule and a scab occurs. Pleomorphism. Pleomorphism is a characteristic features. What do you mean by pleomorphism? All the stages of the rash, whether it can be a papule or a fistule, macule, vesicle, all of these different stages of the rash will simultaneously occur at one time in the same area. You can see the papule, macule, you can just discover all of these stages in the same area. That is nothing but pleomorphism, multiple is pleomorphism. Fever does not run high. The temperature rises with each fresh crop rash. So whenever the fresh crop rashes come in, the temperature rises. Moving further to the complications to the chicken pox are bacterial infection of the lesion. The bacteria can come into the lesions, and then the bacterial infection can occur there. Pneumonia in immunocompromised patients. If the person is already immunocompromised, he could be suffering with HIV, he could be suffering with AIDS, diabetes. So if the person is immunocompromised, then he can come up with pneumonia. CNS involvement. We see the CNS involvement, that's the most severest complication which we can think of in case of chickenpox. The CNS complications, which is encephalitis. You can see here the encephalopathy they have given, the encephalitis. And then we have transverse myelitis, Ray's syndrome, myocarditis. So this is a picture of Ray's syndrome. In Ray's syndrome, what happens? The person suffers with three things. Encephalopathy, hepatomegaly, and varicella zoster virus, which is nothing but chickenpox. That is Ray's syndrome. We also have myocarditis, nephritis. So the heart is getting affected. There is inflammation of the myocardium. The nephritis, the kidneys involvement is there. And they'll also have hemorrhages, the bleeding. Clear? The complications are clear. This is Ray's syndrome, where the person suffers with encephalopathy, zoster infection, and hepatomegaly, where the aspirin is not recommended for Ray's syndrome. And we have encephalitis, transverse myelitis, Okay, including the spinal cord, there's inflammation, there is inflammation of the meninges, and we have myocarditis, the heart is getting involved, nephritis, the nephrons, there is inflammation in the kidney, hemorrhages, there is bleeding, and we saw pneumonia in immunocompromised patients. We have pneumonia and bacterial infection of the lesion. Clear? You can go from top. The lungs, pneumonia, heart, myocarditis, kidney, nephritis, then Ray's syndrome, hemorrhages. Moving further to the prognosis, chickenpox that affects a healthy child is usually a self-limiting disease. So what do you mean by self-limiting disease? A disease which comes on its own and your immunity plays a role, and it's just like that influenza, flu, rhinitis, it comes and it goes on its own. It's a self-limiting disease. Increased morbidity occurs in adult and immune compromised populations. So when the morbidity is the death, the increased deaths are seen in cases of adults and those who are immunocompromised already. Moving further to the diagnosis. Rarely it is required, the diagnosis, you can just make it with the clinical signs, you can clear cut tell that it is a case of chickenpox. The examination of the vesicle fluid in an electronic microscope. So you can see here the electron microscope, the examination of this vesicle fluid in the electronic microscope is going to show you the round particles which have brick shape in smallpox, and this is the differentiation here. The round particles are seen in cases of chickenpox, and the previous session we discussed about the smallpox where it is going to be brick shaped. And we have a PCR test, polymerase chain reaction test, and we are also going to isolate the varicella zoster virus in cell culture. So what are the diagnostic procedures? The examination of the vesicle fluid, and we have PCR and cell culture. Moving further to the differential diagnosis, the smallpox, if you want a detailed the session or the video about the smallpox, you can visit my channel under the playlist Epidemiology of Communicable Diseases. In that chapter you will find the smallpox video. Today we are discussing about the chickenpox. Next session, let's see what's there in the park text and continue. Then we also have measles, contact dermatitis, insect bites, herpes simplex virus infection. So these are the differential diagnosis to chickenpox. So let's just compare between chickenpox and measles. In chickenpox and measles, both the patient suffers with fever. In chickenpox, let's see, we know all the signs and symptoms. The patient is going to have fever, headache, backache, malaise, tiredness, fatigue. Red spots, where do they first appear? First on the trunk, and then face, arms and legs. Decreased appetite, you can remember in the same order, whatever is given in the textbook. Trunk, what did we see? 1, and then we saw nose 2, 3 arms, 4 legs. There will be decrease in the appetite. The spots will turn into blisters, itchy blisters. Now let's see what happens in measles. In measles, the person suffers with fever. Red blotchy rash will first appear on the forehead. Measles, okay, measles. First comes mother. So we have measles first coming on the forehead, the head of the family. Okay. And then we have red inflamed eyes in measles, runny nose, hacking cough and sore throat, Koplik spots inside mouth. So the Koplik spot, which is the most characteristic of the measles. When we discussed about the measles video, we'll go in detail. For now, we got a comparison here. Now we'll move further. Between a differentiation between a smallpox and chickenpox. The fever will occur at the time of rashes in smallpox 2 to 4 days before the rash, and the rash will occur in several stages. Pleomorphism is seen in chickenpox, and in smallpox we see it's occurring in the same stage. Development is slow in chickenpox, rapidly the highly acute, highly infectious disease, so rapidly the progression is going to occur. The distribution, it is more on the body. Here it is more on the periphery. The arms and legs are going to be affected more in cases of smallpox, whereas the body is going to be affected in cases of chickenpox. On the palms and soles usually present, it will be usually absent. Death, one usually dying out of 10 people. Death is very uncommon in cases of chickenpox. Moving further to the prevention of chickenpox. How do we prevent chickenpox? The varicella zoster immunoglobulin can be given. Within the 72 hours of exposure, the varicella zoster immunoglobulin is highly recommended to prevent the chickenpox in the susceptible individuals. Also, if the person is immunocompromised, it is highly recommended that we give the varicella zoster immunoglobulin within 72 hours of exposure. The vaccines are, we see the chickenpox vaccine, the age and the dose is given. The first dose is given from 12 to 15 months of age, and the second dose is usually given from 4 to 6 years of age, or it can also be given earlier. Minimum a gap of 3 months have to be given between the first and the second dose. Okay, 3 months gap have to be given, and the first dose is given to a baby of 12 to 15 months of age. The second dose 4 to 6 years of age. People not being vaccinated earlier, a chickenpox vaccine for adults is also available. People 13 years of age or they are older than 13 years should get 2 doses at least 28 days apart. The first dose can be given to any adult, and then 28 days later you can give them the second dose. The vaccine dose is 0.5 ml is given subcutaneously. The varicella zoster vaccine, the chickenpox vaccine, 0.5 ml will be given subcutaneously. Thank you. With this, we come to an end of the session. I hope all the things are clear. If you have any doubts, put them down in the comment section. And if you like the video, hit the like button and subscribe.